Welcome, Maria, and I will introduce you. Glad this worked out, and we will go ahead and get started. It's just delightful to be able to have you present today. So Dr. Mora Pinzon is a physician scientist, board certified in preventive medicine and public health. She graduated from the Universidad Central de Venezuela, Escuela Jose Maria Vargas, in Caracas, Venezuela, and completed her preventive medicine residency at UW-Madison Department of Medicine, and now is on track as an assistant professor tenure track in the Division of Geriatrics and Gerontology. Her work seeks to improve healthcare access for patients living with dementia and their caregivers, particularly among Latino populations. Among her awards, she was selected as 2018 Young Physician of the Year by the National Hispanic Medical Association and the 2020 William Kane Rising Star Award from the American College of Preventive Medicine. She is currently a faculty scientist with the Wisconsin Alzheimer's Disease Research Center and has a Kane 99R00 from the NIA to look at improving access to Alzheimer's disease and related dementias, care services for Latino populations. Her talk today is on Disseminating Pisando Fuerte for Latino older adults. And Maria, we'll want to stop at at least quarter till, if not 20 tills, so we have lots of time for questions at the end. Thank you and welcome, Maria.
Thank you so much. I'm sorry I'm a few minutes late, internet issues, yay. But no worries, we'll have plenty of time for questions, and thank you everybody for being here. So I'm going to be talking about sharing strengths or borrowing strengths and disseminating Pisando Fuerte. But let's get into this. No disclosures. I received funding from NIA and NIH and also from ICTER, and we'll talk more about that in a second. Important to know, about every 20 minutes, an older adult dies from a fall in the United States. And this statistic, I think, actually is lower right now. But in general, I want to, the main point is to center that this is happening very, very commonly. A lot of times we think about the falls like, oh, there might be some injuries or things like that. Well, no, people is dying. And this is counting only the people that's dying. If we add the number of people that gets injured or just fall without an injury, his number is every 6 minutes, every 5 minutes. There's a lot of people out there at risk of having a fall. And when we think about the Latino population, although right now adults over 65 are just about 7%, 9% of the population right now, that number is going to increase to 21% of older adults by 2060. The Latino population is getting older. We need to prepare for the older population in order to better serve their needs. And that's what Pisando Fuerte comes from. So Stepping On is an evidence-based fall prevention program brought to the United States from Australia by Dr. Jane Mahoney. And Pisando Fuerte is that linguistically and cultural adaptation of Stepping On. One of the things that I want to highlight, this is not just a language translation. This is not just a language. Pisando Fuerte includes a lot of culturally adapted elements and a lot of changes in the delivery that are essential in order to make it feasible and useful for Latino parents. To give you an idea of what is in both programs, and this is the same in both of them, because Pisando Fuerte still keeps the key elements. These programs are multifaceted, meaning that they look at more than one thing. In this case, they do balance and strength exercises. They include visits with guest experts to increase their knowledge and also self-efficacy of older adults in how things like their vision, their medications, their environment are affecting their safety, and also includes multiple exercises for increasing awareness of the issues that are happening, but also the adults feeling more confident in being able to address some of these issues. The adaptation process took place for over several years. But in the brief summary, included a community advisory board and that included also experts in Latino health, Latino engagement, and also fall prevention. Through several meetings, they review each of the components of stepping on and identify what are the things that could be changed, what are the things that needed to stay the same, or what things needed to be adapted to be culturally relevant. This was done before I joined the project, but just to give you a sense, they review every chapter. This was not just a general, oh yes, let's see what we need to change. Nope, we're chapter by chapter, session by session, and review them in detail to see what can be done. This is a summary of the main adaptations that happened, and this is in our paper that was published in 2019. Basically, well, the obvious one, this is in Spanish. Yay! Reading level. Stepping on is right now at an 8th grade reading level, but for Pisando Fuerte, the handouts were made on a 3rd grade level. We know that Latino older adults had a lower level of health literacy. So we needed to use way more pictures, the sentences need to be shorter, and making sure that the information was as simple as possible. The leader manual stayed at an 8th grade level, but trying to simplify as much as possible to make sure that the information was easy to share. One of the key changes, and this was something that is very important, the requirements to be a leader. Stepping on had these following requirements: background as a health allied professional, experience facilitating an adult self-management program, and professional experience working with other adults. If you know a little bit about workforce right now in the United States, just to give you a sense, the nurses, Latino nurses is about 6%, 7%. Latino physicians, 3% of the workforce. So when we think about that reduced number of Latino or professionals that are Spanish speaking, it was decided that this needed to expand. And the background was expanded to also include fitness experts, community health workers, promoters, educators, people that have experience working with Latino adults on the health-related fields, but that might not have those RN, MD, OT at the end of their name. And this was one of the things that was essential by community organizations, because they say, how could I find somebody to do this if I only have a health educator or a promotora or somebody with just a high school education? And we'll talk about more of the implications about this change later when we talk about the training. The sessions remain more or less the same. Main thing is that there were a few sessions that were adapted or included. So, for example, Pisando Fuerte has how to talk to your doctor, which was modified. This was not a huge emphasis in stepping on, but it was decided by the Community Advisory Board that was a very key component, because Latinos do not talk to a doctor. And one of the things that we wanted to do in Pisando Fuerte was that people feel more confident talking to a doctor about the medications and the side effects. Latino older adults might say, oh, I'm okay, this is normal. But that's not what we want. We want to make sure that people know that they can talk to the doctor and ask questions. One of the other things and this relates a lot to the delivery. Remember, I said healthcare professionals that can speak Spanish is a very reduced number. So getting them as an guest experts to come to visit for about 45 minutes, an hour is very hard. So we added the option to have English-speaking experts, but also using an interpreter. There were videos recorded with experts so that they could be shown if they were not a Spanish guest expert. And also there's instructions in the manual on how to work on this bilingual session, how to make this happen. There were other changes about the delivery, for example, including cultural values, making sure the materials representing the culture and allow people to actually talk about things that were relevant to them. One of the examples that always calls my attention, examples in the stories, for example. Most of the stories in Stepping On refer with adults living on their own or living with just a partner. Then in the stories for Pisando Fuerte, we emphasizes the cultural value, multi-generational families, having in a household where there's kids and other adults, and there's how to manage all of those natural situations and how to use those stories to enrich the program. The story of the program is a little bit, I'm going to make it simple. So the development started in 2011 with a grant from CDC. There was a pilot done with the United Community Center in 2012. This pilot trained everybody in English to deliver the program in Spanish. And one of the first things that say, this quote I always remember, having us taking the program in English, for then us in our minds having to relate to Spanish was a big mistake. From the beginning, facilitators were saying, we need this material in Spanish. We need to learn the language from you in Spanish, not just you tell us to translate in our head.
Mm-hmm.
After that, there was a non-randomized clinical trial done at 2 organizations, UCC in Milwaukee and NESCO here in Madison, 2014 and 2015. Refinement after learning all the things from the pilot, what are the things that worked, that didn't work, and incorporating new elements. One of the main things I was learning the pilot was it has to be fun. And I know it sounds obvious, but it's not. So how to incorporate a lot more of those fun aspects. Then I joined the program about in 2017, and here came the main question. Do we need a randomized clinical trial? Or do we have enough evidence to go to the dissemination phase? And that's what we're going to talk about today. So some of the things that we had evaluated by that point were the number of people that were screened and enrolled, the falls after 6 months, the adoption, what are the through interviews, what are the barriers, facilitators, and also how good people deliver the program and how by individuals and participants incorporated the things that they learn in the program into the daily life. We had all of this data. And this, but again, this came from 24 people only. At this point, there were 36 if we count the first pilot. But the good thing that I really like about so far the data that we had is that really represented the community and the people that we were trying to serve. I want to highlight of the people that have taken Pisando Fuerte at this point, 8% of them had no formal education. They did not know how to read. This really reflects the people. These were not just people with college educated that we just reached and through the listserv of the university. Nope, these were community members. That means that the program, if it works in this group, it can really be generalizable. We have people from all, not only Mexican Americans, we have people from Colombia, Puerto Rico, or the other group includes, I think, Cuban and Peruvians. So and it was a very well received. So the question was again, how do we really need to test this a little bit more? How much is necessary? At the time that we were asking this question came this paper from Dr. Aarons called Scaling Out. And scaling out refers to the implementation of evidence-based interventions in novel circumstances, distinct from but closely related to previous implementations. So, and he defined 3 different categories. Type 1, you have same population, different delivery system. An example will be if you are doing a program for wound care that is usually delivered in the hospital, but now you're going to take it to a home care basis. That's a same population, you're serving the same community, the same group of people, but a different way. Type 2, different population, same delivery system. Maybe now the same, imagine wound care. Now it's not just for people with burns. Now we're going to do it with acne. Different population, but same delivery system. We are still inside the hospital using the same tool. Type 3, different population, different delivery system. Now you're trying to use the same program to treat acne in a community setting. Nothing stays the same. But he referred that in these cases, we can borrow strength. We can utilize the evidence from the previous implementations to decide if further testing is necessary. And for that, he defines the levels of evidence as these 4 levels. 0, minimal evidence. 1, proximal empirical evidence. So 2, direct empirical evidence. And 3, evidence from a randomized clinical trial. And they evaluated these 6 domains: implementation of fidelity, intervention of fidelity, reach, adoption, sustainment, and health outcomes. And I'm going to define this in a minute. But basically for each of these, they define sort of what is the minimum amount of evidence that's needed? Just to give you an example, this category, look at the lower corner, lower right corner, type 3 scaling out, different population, different delivery system. In this case, they're referring that for that you're changing everything. So you need a randomized clinical trial to really evaluate the health outcome. But if you're just changing one of the things, you could probably use empirical evidence or some evidence from similar studies that supports your theory. So we decided to analyze Pisando Fuerte using this framework. Then let's see how we did. The first question, implementation of fidelity, proxy for empirical evidence. Basically, the question was, are the implementation tools that are being used evidence-based, and there's evidence that these ones work? That's the main question. And the answer is yes, we are using the same tools for implementation that Stepping On was using. Just an example is the assessment of readiness of the organizations, training for the facilitators or leaders using a structured course. All of the manuals, educational materials will be provided, and there's a centralized technical assistant. This is just some of the tools that we were using. And these were remaining the same. So the delivery system was very similar, using the same tools that are evidence-based. So I think we were pretty good on here. We were not changing that. Now we go with the fidelity of delivery. How the good is the program being delivered as intended? And here's the information that we had before. So Stepping On have developed the key elements through a Delphi consensus are defined, and these are the things that have to happen to ensure that there's fidelity of the program. We did an analysis of a previous, and it was said that in order to say that the program is being delivered with fidelity, you need to have 80% of these elements present. For Pisando Fuerte, we had some weaknesses. There was a little bit of weaknesses on the adult learning processes. An example is that sometimes the facilitators ended up teaching and just mentioning rather than letting participants to learn on their own or asking questions. Program aspects, sometimes the facilitators were rushed of time and needed to cut sections. Upgrading exercises, sometimes the facilitators were afraid of the participants doing too much, so there was not an encouragement for them to do the exercises a little harder. And the cultural adaptation, you might be wondering, wait, well, that's very, very low. This was designed for this study particularly. And one of the things is that I think we did not evaluate cultural adaptation in a way that was meaningful. The way that we evaluated the fidelity of delivery in the cultural adaptation is how many times people use familism, how many times people use Marianism or the cultural values. When it actually, and then it meant that you needed to do too much, many times in order to get this point. So we changed it for future adaptations. We just reflected back what are the important things, minimum things that need to be put in there. And I'll show you the results later. Looking at reach. Now, reach, remember, refers to, are we getting to the people that we need to get? And also, are we enrolling the people that we are inviting? For this, we compare with previous Stepping On studies where we see that of the people that we screen and enroll, about 80% of them completed the first study and the baseline, and 87% of them completing the actual program, the 8 weeks, which was very, very similar to actually Stepping On data, where 80% of the people that's screened and enroll actually complete the baseline, and 82% of them complete the program. So this was a good direct empirical evidence for us. We see, I have the numbers, Pisando Fuerte did just as good as Stepping On in this area. Let's keep going. Adoption and sustainability. And here is where we start seeing some of the proxy evidence. We don't have direct evidence comparing one-to-one. It's more about the things that we heard from the organizations and the interest in the intervention. So most of the time, the organizations that we approach want to participate, and they are open to continue the program once the study ends. There's always interest from multiple organizations and about when is the program going to be available, and there's also funding through ACL to sustain the program over time. But again, this is proxy because it's not sure. Nobody signed off the contract, say, yes, I'll do it. This is just interest, what people is thinking about. Now we go to health outcomes. Does Pisando Fuerte work? The short answer is yes. The long answer is falls is hard to measure in the sense that falls are a rare event. In a group of 25 people, we only had like 2 falls before the 6 months, or 3 falls before the 6 months, and then 1 fall after. At the end, looking at the numbers, that was a decrease in a 68% of the number of falls, and comparing with the stepping on data, that's a 48% in an implementation study. But one of the harder things, again, this is falls per person for 6 months. When falls is a rare event, it's not something that happens every day. These numbers need to be very, very large to see statistically significant. For Pisando Fuerte, that number does not reach statistically significance, but it's a matter of a power. We needed to have like 100 different people follow for longer time in order to reach power. But looking at the other things of the evidence, because it's not only about falls, it's the implementation of these behaviors. Is people taking safe behaviors? The short answer is yes. We use a survey that was validated for this purpose about prevention behaviors. And in Pisando Fuerte, people were more likely to actually use those behaviors and feel better at doing those behaviors. And simple behaviors. It's like, hey, I'm not going to go out when it's raining, or I'm going to I'm going to take the handle when I'm going down the stairs. That's very measured. And that was statistically significant and matched the evidence for us of the implementation trials on stepping on. We saw even a little larger increase, but again, not difference, statistically significant. It's the same between Pisando Fuerte and stepping on. People is learning, people is incorporating what they're learning, and this is what we want to see. I'm talking about incorporating those learnings. In Pisando Fuerte, after 1 week, 58% of the people were doing the exercise. After 6 months, 58% of people were still doing the exercise. So this is super encouraging because it's telling us people, it's not only doing it because they just got out of the program. They found it meaningful enough that they kept doing it. And this is what we want to see. At 6 months, 67% of them had eliminated hazards at home. 67. Usually the most common things that I heard after the programs were, oh, we just took out the rocks and I make sure I ask my son to fix that stair or things like that. 94% of them reported changes in walking and standing after 6 months. And when you ask them after 6 months, how is it doing? They are so proud to tell you that they are walking slower, they're taking a look, paying attention where they're going. And that's a badge of pride. They really like that. And this is what we wanted to see. And this is why we felt, hey, this is a good evidence. We might not have seen a change in falls, but people is doing the things that they need to do to prevent falls. That's what we wanted to see. So now coming back to Aaron's framework. He said, in order to move to the next stage or consider that you have enough evidence, this is the minimum required. You need to have evidence that's 1 or 2 for implementation fidelity, proxy or direct. You need to have the same for intervention fidelity. We need to have at least direct evidence of reach, some evidence of adoption and sustainment, and there's no need for evidence of health outcomes. Because we are using the same delivery system, which technically should work the same way. And Pisando Fuerte, we had everything. So we met the minimal criteria to go to the next stage without needing a randomized clinical trial. I already said this. Then what happened? This is what nobody has seen before because we just have done a couple posters on this. So we decided that we were not going to do a randomized clinical trial, but we still needed to do some more work in the program. Then what was needed? Refine the program to include more culturally appropriate examples. As I told you, the stories, multi-generational household or things like that. Develop a training program that was available in Spanish for facilitators with limited English proficiency, and complete the translation adaptation of ancillary materials. I mean, you have no idea the amount of little things that are out there. Like the little brochure and the checklist and the other checklist And the third checklist. So there's so many little things out there that we just need to make sure that everything was in Spanish and it was reflecting of the program. For example, Pisando Fuerte has 8 weeks, stepping on is 7. So it's revising all of the materials to make sure that there's no that 7 somewhere going around. Then the hardest part of this was the leader training, making sure that it was not only serving Pisando Fuerte, but also serving the organizations and serving the facilitators. We did 14 modifications that I think they were not just little things. I mean, they were significant modifications. One of the and some of the things that we changed, well, besides doing it in Spanish, examples were culturally adapted to display important Latino values. I think some of the example is sometimes when you offer a fall prevention initiative to an older adult that's Latino, they might say, God will protect me. I'm fine. So included in those training is like how to respond to those type of things in a way that's culturally appropriate. One of the things that we did is that we give the people the freedom to say, how would you answer? And they came up with the answers. They say, well, this is how I approach this. One example is, yes, but also God is putting us here in your path. Maybe he wants you to take this because God says, help you and I will help you later. So it's how to approach these topics in a way that we know is reflective of who we are. The language that we use, we expanded to include different regional words for important concepts. And I always give the example of the word calf, the calf muscle in your leg. I found 8 different words used across different countries and giving that to the facilitators because you don't know who you're going to encounter. So giving them extra words that they could use so that they could connect with participants regardless of where they are from. All of the materials were in English and Spanish. This is one of the things that we learned this last session. Some of the facilitators that I was training were heritage speakers. That means that most of their education and training was in English, but they learned Spanish. That means that they don't feel comfortable reading in Spanish. They are fine talking about it, but they took a lot of time in reading and understanding the materials. And it was hard for them. I gave the group only the information in Spanish for one session. Then when I gave them in English, they were like, oh my God, this is so much easier. I can read it in English, internalize it, learn it, and then do the practice and the program and the training in Spanish. I feel way more comfortable. And that's one of the key things in talking about heritage speakers and native speakers. The program is for everybody, but everybody needs a little different tools to learn. And that's to keep that in mind. Adding elements. We needed to create new materials. For example, how to find guest expert. This is in the training, this was on days in the second day. We were 1 hour into the training the first day, and we spent an hour talking about this. This generated a lot of anxiety on the facilitators, how to get the guest expert, how to train the guest experts. And we created new additional materials and support so that it could facilitate them. We created exercises and practice so that they could practice in the room in a safe environment, how to redirect a guest expert, or how to correct a guest expert, something that many of them would have never thought of doing before. And again, this is understanding who are we training. We are training people that might not have been in this environment ever. Community health worker, promotora, somebody with just a high school education, and now they need to correct a physician that's coming here to talking about something that might not be what we want them to talk. An example is sometimes we want people to refer to falls. But maybe the person that's talking about medications is talking about just hypertension control and managing the diabetes, but not getting to the falls aspect of the conversation. So how do we say, hey, I'm sorry. What about how is this related to falls? It's hard. It's really hard. So giving them the confidence that they were the bosses in this scenario. Removing or skipping elements. I'm telling you, again, coming back, who are we training? If you spend an hour of the training talking about this is a randomized clinical trial and blah, 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 you lost them. So we remove information that was not relevant and just keep the important information for the training. Although we still give them everything and they could read it. It's just we did not emphasize it in the training and spend a lot of time on that. We did a lot more practice. The practice sessions went from 45 minutes to 90 minutes in some cases. And we added practices, making sure that the things that were questions, they were addressed and expanded. Some of the segments were moved to be self-paced and training. So again, minimize the number of things that we needed to cover in the training. There were a lot of videos created so that they could learn before coming to the program. And finally, the training that was, the evaluation quizzes were offered in English and Spanish, coming back to the language and heritage speakers. And this was one of the persons that I trained. She was a heritage speaker, and she said, "I'm sorry, I think I failed the test because it's in Spanish and I'm not comfortable reading in Spanish." She spoke perfectly. I would have never guessed that, but she had just a hard time internalizing information in Spanish, reading it in Spanish. So I gave her in English and she passed with flying colors. So you might be wondering, did it work? Oh yeah, it did. So we trained 6 individuals from community-based organizations, 3 of them heritage speakers, 3 of them native speakers. They all rated the training as very, very useful in a range from 1 to 3, being 1 the best rating. They reported that the most important thing was the practice. This happened during COVID, so we had to do the training virtually. This was also new, but I'm not going into the virtual trainings and adaptations because it's outside the scope of this study, this presentation. And the main thing, did it work? Did it help to make the implementation better? And absolutely did. So in blue, we have the pre-adaptation. This was the previous studies. What was our fidelity of delivery? And in orange is our fidelity of delivery after this new training was implemented. We can see that in all of the areas we're above that threshold. And it's not only a little better. In some cases, it's very, very, very higher level than it was before. And I'm very proud of this. Why? Because it meant that not only they learned, we had a good time, they were able to apply this in the way that we were intended. But now you might question, did the program remain the same with participants? Well, they increased the self-belief. But we were only testing in 31, so we did not have enough power to show differences, but in every single aspect, the participants improved their knowledge and their beliefs that they could prevent falls. And actually, I can't find a way to reduce falls was statistically significant. They learned a lot. After, we're asking about satisfaction with the program. Most of the participants always refer that they like it. And I will point out letter A, for example, I feel comfortable talking to my healthcare provider about my medications. In total, 72%, 74% of them say, yes, I will feel comfortable. That number makes me happy. I feel more comfortable talking about my family, with my family or friends about falling. Again, 80% of them will feel more comfortable. And some of them refer, yes, and I used these flyers that you gave me to talk to my son that I needed some repairs done at home. I feel more satisfied with my life. 90% of them were more satisfied with their life. So in general, we know that the participants enjoy this. And again, 60% of them did the modifications at home, such as installing grabs, securing loose rocks, things that are hard to do, and still most of them did it. In conclusion, we know Pisando Fuerte is feasible, is useful for Latino communities. It shares a lot of the benefits and challenges with stepping on. We use the borrowed strength to accelerate their dissemination and adaptation. Because Latinos, we're still human. We still have the same muscles. Remember, race and ethnicity are social constructs. So we adapted the things that we needed to adapt, but still the exercises work for them, the activities work for them, and the program still have a lot of benefits. So I'm very, very, very happy with the work that we're doing. And thank you for everybody involved. This is everybody that has been in all of the stages from the beginning. I don't have enough time to present about everybody, but they're awesome. And we receive funding from ICTER and also for the Retirement Research Foundation to do this project. And thank you so much. And we have plenty of time for questions.
Thank you so much, Maria. This was fantastic. And there was new information I hadn't seen before, which I just loved. one thing I want to say, and then we're going to have time for questions. One of the other things I think was a really unintended positive outcome is we learned things from the cultural adaptation that then got back culturally adapted and added to stepping on for English speaking. So for example, we realized that facilitators across Wisconsin need more training in how to talk with guest experts, how to work with a guest expert. And so that was added back to the training for English speaking leaders. We also learned that there was a key element that we did not appreciate until we began this work, which was that the workshops need to be fun. And so we took that key element, made sure that that was incorporated back into the stepping on for North America for English speaking. So that was a wonderful aspect of sort of learning and then retailoring for the English speaking audiences. So we encourage you to use the chat feature or raise your hand for any questions or comments you may have. I think we'll have to use the chat because we can't see individuals. So if you can put your question in chat, we can mute you and ask, and you can ask it. Anand, is it possible to unmute him to ask his question, or should I just ask it, Kathy?
I can
Go ahead,
answer.
Maria. Yeah, just address it.
I think one of the main things, any resources to support patient self-advocacy. Couple of the things that we, and again, this work started before I was in the project, but some of the things that I have heard, for example, we do a lot of role play. One of the things that particularly how to talk to your doctor and promote the questions, we spend about 35 minutes doing role play and showing people different strategies, but it's a lot of the adult learning. Letting them take the reins and say, what are you gonna do? And re-emphasizing multiple times that it's okay, it's totally fine. Here's a few extra tools that you can take. So one of the things, for example, we do is a medication card. Hey, and one of the exercises is take this to your pharmacist or your doctor the next time you go and talk to them about all of your medications. And that's emphasized for 3 different lessons. And it's keeping that consistent. And when they talk among them and using the group as a setting for reinforcement. So it's always good when then the next session they come and somebody says, oh, I did this and it worked well. That helps a lot of that self advocacy, that people feel more comfortable doing it. And that's the thing, that the huge advantage of the small group. So I'm happy to share the things that we do. But it's not necessarily that we give them, here's a flyer to how to talk to your doctor, but no, we make them practice and do it in the session and see it and play around it so they feel better. Now, Jane, you have something to add about that?
Well, the only thing I'm going to add is that the Stepping On program was built on self-efficacy, Bender's self-efficacy framework. And so the adult learning aspects and the group facilitation are really all designed to enhance self-efficacy. And so things like using group problem solving, telling stories to share what they've all learned and do, to keep doing the exercises to prevent falls, and as Maria alluded to. So I think either Maria or I would be glad to share the Stepping On materials, which really demonstrate use of self-efficacy principles.
So nobody has asked this, but I think I got asked this a couple times in conferences. Is it better to adapt or start from scratch? And the short answer is there's not right or wrong answer. I think it just depends on what is the work and how it's being received. But the first step is that having that in the regional setting, the first adaptation, having the community advisory board and the people interested in using the program be part of that process of deciding, is this something that we can make our own, that we can feed our needs? That's the first step. It's not only adapting because of the sake, like, oh yes, let's adapt it because we already have it. Is people interested of this? Will this meet a need? And that's I think the first question. And I'll say again, there's no right or wrong answer. There's advantage and disadvantage. I think a great advantage for us is that we could borrow the evidence from stepping on, certainly. We didn't need to do a whole randomized clinical trial, but if it were something different, probably needs a whole randomized clinical trial. So this is one of the things that I wanted to highlight, that there's no right or wrong answer, and it's about talking. And I think that I will advertise the Launchpad. They will be very helpful in early stages to identify what's the need, what's the interest, and how to get a little better sense of what might be the best way to go for your particular intervention or work.
Maria, I think one of the questions I have is if you could just comment a little on one thing that maybe surprises me, but just doing the cultural adaptation of the intervention was not enough. You also had to culturally adapt the training. And so I wonder if you could just comment on sort of the what do you see as the distillable methods for culturally adapting a training, and to make sure that you've done the best job, the right job? And how do you know, just sort of, is there, I don't think D&I methods really talk about aspects of culturally adapting a training as much as culturally adapting an intervention.
Yeah, I think I see the training as an intervention. I think that's the first thing. And it's sometimes very hard to differentiate because in this case, the outcomes are the delivery. I'm not looking at the participants is very far down the road. But I think one of the is going back to what we were saying of who's the audience. In this case, it was not thinking about the audience as the participants that are going to be in the program, but the audience is the organization and who are the members of the organization. The cultural adaptation of the training also had a second benefit, is that demonstrates what the training serves as an opportunity to demonstrate what we want the facilitators to do with the program. If we don't incorporate the cultural elements that we want them to display, then that's a missed opportunity for them to see how those our culture enhances the program. And I think one of the examples that we did in the cultural adaptation of the training was that we use music, and we welcome everybody with music. I just put some merengue, some salsa every morning to energize us. And that's something that then many of the facilitators incorporated into the programs. And that's a very teeny tiny example of that cultural adaptation. Is it against stepping on to use music for welcoming? No, but it's unique to us. So it's about making sure the people that were going to be in that training also saw how they could get ideas how to do it. I think there were some adaptations that happened by chance, and we were not expecting to having to do, that was an adaptation. I guess it was. Particularly on the delivery and the exercises, that it came from the questions that they had when the facilitators, and these are then the post-mortem, let's say, after the training, where we needed to adjust the order of the sessions based on the questions and the concerns and the anxiety, and that was related to doing the program they never had experience. So it was several things that we haven't done already, but we sort of know that they will work because they are responsive to the things that people say. So the cultural training, adaptation of the training, I saw it as another intervention adaptation, but it's hard because you need to, I had to disconnect what will happen to the participant because we don't have enough information or enough sample to really go too deep into that aspect. But it's important.
There is another question in chat of a lot of our dissemination is aimed at individuals with intellectual and developmental disabilities. We'd like to offer this in more languages, offer this in different languages to make it more accessible. Were there any individuals at the intersectionality of also having a disability, and how did that affect materials?
The short answer is yes. The long answer, well, we need to talk about this. So because we're working with older adults, we didn't have anybody with developmental disabilities being part of the groups. And I think this reflects is just who is being served as part of the organizations. But the type of disabilities that we had were the ones that we always think on older adults, like lack of hearing, difficulty with vision, difficult mobility, and that affect the material. So all of our materials are big font, like very big font. Because we knew that there were also issues with hearing. And this is for the stepping on. There's a specific materials and trainings for facilitators that gave them the best practices to work with people with difficulty of hearing. There's also a manual for how to work with people with that difficulty of vision, and all of the exercises had extra safety precautions when working with people that have difficulty on mobility that require, for example, a cane, or they require a walker outdoors for balance. So, but is it I think, and this has come down to the fact that we screen for those things. And this is one of the main things. When in the screening process, before the participant gets into the program, we ask about a lot of those things to make sure that it's safe, that we can deliver the program effectively and not just see what will happen. So I cannot say how many people were excluded from participating in the program because maybe they don't feel that the program was safe for them, or how many people were they never were approached because they had some disability and the leaders never say, hey, this might be a program for you. So that's, I think, again, the long answer. There's a lot more to talk about in this field, and certainly we have not we are just scratched the bare surface, and we have not gone into that.
I think that comes back to the idea of the checklist, the extra tools, so that you create a system for the facilitators to be successful in making sure that they have participants who can really benefit from the workshop.
Yep. And this is the checklist. I mean, you have no idea how many checklists we needed to translate and revise and modify. And yeah, and it's important. And one of the hardest things, I think, for facilitators is saying no. I know we receive inquiries from people that would not have been able to do the program safely. And that was part of the training, how to tell facilitators, like, no, you have to say no. I know it will break your heart, but the program is not designed to be safe for people that need a walker at home and have extra mobility issues. So that's also part of the things that we had to emphasize in the training.
So another question, Susie Fernandez, great presentation. Considering the familial multi-generational aspects you mentioned, could you provide information on how these were incorporated into the intervention and training? Great question.
I love it. Yes. So this was very intentional. So the ways that the family was incorporated in the intervention mostly. One, stories include more family and include more relationships with daughters, grandsons, granddaughters. The stories, that's one aspect. Two, all of the materials are given bilingual, English and Spanish. Multi-generational households might have younger generations use only English. We wanted to make sure that the older adults feel safe sharing the materials and that the people will be able to understand them and help them in taking some of these behavioral components. So all of the things were done in that aspect. The last people is welcome to bring a guest. If they say, oh, I'm taking care of my mom, but I need to give her a ride, can I stay in the session? The answer is yes, and there's a specific protocol for facilitators to welcome somebody as a guest during the session. And the last day is a celebration where people can bring their families, they get a diploma, and they can do a celebration with everybody that they want. Could we go deeper into included the facilitators the families into the session? We probably could, but that would be something that we have not really explored.
Thank you so much. I do want to give a shout out. We do have an attendee from Wisconsin Institute for Healthy Aging, which is now disseminating, stepping on, providing the trainings, technical assistance, and now is doing that with Pisando Fuerte. And they have also done a cultural adaptation for Native Americans and to adapt it for tribal culture. So I think it just really points out the importance of doing that adaptation for reach and behavior change and sustainability. So thank you so much, Maria. This was excellent. We really appreciate this. We do have a link to a REDCap survey in chat, and we would love to have everyone complete the survey so that we can get your feedback. And thank you again.
Yeah. Thank you, everybody. Please fill out the evaluation. I really appreciate it. Thank you, thank you, thank you.
All right. And have a good afternoon to everyone on this rainy day.